Well, I'd like to welcome Dr. Timothy Owolabi to the podcast today. I really appreciate his being here with us today. He's a physician advisor and medical director for care management at Summit Health out east in Pennsylvania. Thanks for joining me today, Tim.
Well, thanks, John, for having me on your podcast. I'm really honored that you've invited me and wanted to applaud you for all the time and effort you've put into this podcast and onto your website.
Fantastic. I really appreciate that. You know, I heard you speak at the recent Seek conference, I think it was in October, and you were talking about your role, and I thought the listeners here would love to hear your story, so we can get right into that.
Sure.
All right. Why don't you start by just kind of defining your current position and what you're doing there at Summit Health?
Well, I thought that I would first start by talking a little bit about the various titles that are used for the position that I'm in. I am a physician advisor, as you said, but that was really the beginning of my work with Summit. The position's evolved into being one of medical director. And for me, I'm a medical director of care management, but in other places, the title is medical director of utilization review or medical director of clinical documentation improvement, or even medical advisor. And there's a lot of overlap between these various titles, but oftentimes they are serving similar purposes. And so the job duties can vary, but I think in most places, physician advisors will do what are called level of care determinations, which is determining appropriate statuses for patients, will be involved in denials management, and also involved in education, both the lay public, patients and families, and also physicians. And I'll be passing the 2-year mark in this role in a few months. And we've really expanded from when I began. I was just myself as the single full-time physician advisor. Now we have 2 full-time physician advisors and also 2 part-time physician advisors who are local physicians who are on medical staff at our hospitals. And we are contracted with a physician advisor vendor company that helps us with emergency coverage. And actually, in a month or so, I'm going to be adding the role of medical director of clinical documentation improvement as well.
Nice. So it sounds like they're really ramping up the activities there. Was that driven by cost concerns or denials? What was going on?
Well, I've been able to quantify the amount of work that I do, as well as the impact of the work that I do, and was able to make a case to our senior management about the need for more resources. And when they looked at the cost of outsourcing a lot of the resources, because I can't work 24/7, 365. So even before we got to our current arrangement, we had to use supplemental services. So when they looked at the cost of all that supplemental service, it made sense to restructure our program. And so that's how we've evolved to this point.
That is very impressive. You know, if you can get the CFO on board and show that there's definitely some value, then they're willing to invest in that kind of professional service for sure. So that you're to be commended for that.
Thank you.
So maybe you can go through and maybe a little more detail about what the care management department does and how things kind of balance out in your department in terms of how much is spent on face-to-face or phone calls with physicians versus denial management and other duties.
Sure. Well, the physician advisor position is really the only physician in this department, care management, except that our department is overseen by one of the VPs within the organization who also is a physician. He's one of our chief medical officers. So otherwise, the department is staffed almost entirely by RNs. And as I said during the Seek presentation I gave last month, care management really is like a guide for patients. And, I use the schematic of a maze because the health system really can feel like a maze from the patient's perspective. And so care managers are the guides to help patients through that maze. As I said, it's mostly staffed by RNs, but there are also a few LPNs and social workers. And the moment a patient comes into the hospital and gets registered, the care manager will put the clinical details through a screening process to determine the appropriateness for that patient to be in the hospital. And the screening tool we use at our hospital is called Interqual, but the other commonly used tool is called Milliman or MCG. And actually, insurance companies use a similar process when they're deciding whether or not to cover a requested hospitalization. And so once that screening process is done and the appropriate status has been assigned, then the patient will notify the insurance company. The care manager will notify the insurance company that the patient is in the hospital, and then they'll send clinical information. And that clinical information is how insurance companies will complete their screens. And almost immediately, the care manager will begin preparations for the patient to be discharged. If those preparations were delayed until the time of discharge, then the discharge would probably be delayed. So that's why this really needs to start right away. And, these preparations can be getting authorizations for medications, arranging durable medical equipment, arranging follow-up appointments, and arranging placements in cases where patients need to go to a skilled nursing facility. And social workers are oftentimes involved in those sorts of things, as well as other issues related to social determinants of health, like transportation, food insecurity, housing, and again, placement when a patient can't live independently. And then so finally, the last activity of the care management department that starts at the RN level is denials management. So if the insurance company determines after getting those clinicals that they don't feel that hospital level services are appropriate, they could issue a denial, and we have to decide whether or not we have a strong enough case to appeal it. And so that's where the physician advisor will become involved as well. In some cases, we have to accept the denial, especially if it's an administrative denial. In some cases, it's a coding issue, or it could be that the patient was recently in the hospital and they feel that this hospitalization is just a continuation of the other, and they'll link the two. So that's one activity of the physician advisor, the denials part. But then on the front end, the physician advisor, as I mentioned a few moments ago, is involved with level of care determinations. Mm-hmm. If the screening process determines that the patient isn't appropriate for the level of care that they've been assigned, or not even appropriate to be in the hospital, then that case will be directed to the physician advisor to make a determination and document it.
Absolutely.
So I think that's pretty much an overview of what happens in care management.
It's definitely a critical need at a hospital to keep patients flowing, to make sure that their length of stay is appropriate, that they're in the right setting, and so forth. So I remember at the conference, as I heard you speak, you sounded very passionate about what you're doing. So I'm curious, what is it about being a physician advisor and medical director of care management that you like? What's the good parts for our listeners to consider?
Well, I like the sense that I'm able to use the medical knowledge and non-clinical skill sets that I've acquired over the years, be it in coding and compliance, health informatics, and some of the critical thinking skills that I've acquired in the service of the community. I like that I get to be a content expert in something that's challenging, like utilization review and the regulatory environment. But honestly, I really like the fact that I'm no longer on the RVU hamster wheel, and I get to deliver something of value that isn't simply based on the volume of patients that I'm seeing. But that being said, I appreciate your kudos earlier that I'm still able to quantify the value that I bring And, when I'm involved with denials management, I get a denial overturned, or when a patient has been placed in a status called outpatient observation that pays less than a full admission, which would be inpatient status. Each time I'm able to recommend a conversion to a full admission is a gain financially. And so these are the things that make our CFO happy. And so the last thing I would mention that I really enjoy about this position is the fact that I'm increasingly more involved in the organizational strategic planning. And it's something that I think will be handy as I look to advance professionally. But there's some soft benefits, like the fact that I can work from home if the need arises, because I can remotely access the network.
That's very nice. So you have a little more flexibility, and you get to use these other skills that you've acquired over time. One of the things that I address occasionally here is the fact that some physicians sort of feel, if they're looking for a non-clinical career, that really the being a physician was sort of the end of the journey. And as you've pointed out, really becoming a physician advisor and a medical director is actually the prerequisite to do that, is to be a practicing physician that knows what they're doing. So sometimes we need that shift in our mind that, no, it's not the end of the road. Becoming a physician might be the beginning of the road for an even more extensive journey.
Very true.
So that's very interesting. Now, I remember in your presentation that you talked about the three roles of the physician advisor, and you kind of touched on them, but maybe you could be a little more explicit and kind of review some of those roles, the three roles that you talked about then.
Sure. Well, the three roles were the advisory role, the administrative role, and the educator role. And I think I already alluded to education. It can be both for the lay public in the form of patients and their families, and oftentimes if there's a question about status or some regulatory issue, the physician advisor may be asked to participate in a family meeting. But as far as educating the medical staff, it's usually in the form of CME events, grand rounds, or sometimes just one-on-one discussions, when status determinations need to happen, or if there's been a denial of a claim. Mm-hmm. Now, as far as the other two roles, the advisor role and the administrative role, I'll take the advisor role first. The physician advisor is a content expert. So, you are expected to really understand your regulatory environment and the contracts that you have with insurance companies, but also just basic UR competencies, understanding interqual or understanding MCG. But even though you are an expert, you don't really get to exert supervisory power over any of the physicians. So in my talk, I described the physician advisor as a diplomat. Mm-hmm. Really have to figure out how to exercise soft power. The CMO is usually the one who, is expected to use the stick in instances, whereas the physician advisor really has to dangle carrots. And the administrative role, I think, is what distinguishes just a bread and butter physician advisor from a physician advisor who's a medical director. So, you are involved in doing level of care determinations and appeals of denials and educating as a physician advisor. Once you move into that medical director role, now you're thinking more about how is it that we get patients the right amount of care, get them placed in the right status, get them managed based on the best practices, and we make sure that the hospital is reimbursed appropriately. And so in thinking about all of these things, the medical director will use data, in my SEEK talk, I referenced a data scientist named W. Edward Deming, who said, without data, you're just another person with an opinion. And so I think that, for many of your listeners, that's especially true if you're a physician. And I would ask, how often have you seen anyone persuade a room full of physicians of something without producing data? Mm-hmm. So as the administrator, being able to gather, interpret, and communicate data is really important.
Do the physicians that you work with, have they been fairly open and collegial? I know there's probably some hesitation in our listeners that, well, I don't know that I want to be calling a physician and trying to explain why their patient has to be discharged or they can't get this test. So it's probably not a big issue, but what's your experience been with that kind of thing?
Well, I think the 80-20 rule is appropriate here. I've heard someone say that oftentimes 80% of physicians are likely going to be easy to work with and kind of understand where you're coming from, and 20% may be the ones that are more challenging to connect with and get cooperation from. And so you really should focus on the 80% and know that you will come up against some resistance with some folks, and you work with them the best that you can, but you don't let that take your eye off the fact that most physicians are going to welcome you because you are helping them deal with something that in the past they would have had to deal with. They would have had to do those peer-to-peers, and also they would get a lot of inquiries about mistakes that happen, that if you are helping to advise them ahead of time, they could cut down on the number of inquiries that they get. And so I find that framing what I do when I talk to a physician as I'm there to be their advocate and be an advocate for their patient really makes these relationships very collegial.
Healthcare is becoming very complex. Navigating, the hospital can be very complex. And it sounds like what you're saying is that you need to be a collaborator. You need to have negotiation skills. So it sounds like you need good communication skills to work well in this role.
Right. Absolutely.
But on the other hand, too, I think that physicians, from my experience, they appreciate having another physician to talk about these issues. They don't necessarily take it well when an RN or an LPN calls them and says, well, you can't do this or you can't do that, versus talking to a physician who is explaining, here's how we navigate the process.
Exactly. And actually, that was another point that I had meant to make, that it's really helpful if you are working in a system where you know the physicians, if you've practiced among them, because you're actually their peer. And I think that that is also part of why the physician advisor role has evolved to the point where most hospitals want someone in-house. Once upon a time, it was common to have remote physician advisors, that would work for another vendor.
Right.
And, that was just a disembodied person on the phone calling physicians. And oftentimes medical staff were not happy with those interactions. And so I think that medical staff acceptance is much better when it's someone that they know and someone who they can see on a regular basis. So I think as daunting as it may be to have to approach physicians where you feel that you may not be delivering news that they want to hear, I think it's really a lot smoother when you already have collegial relationships.
Absolutely. And I think things are changing only because new grads and people that aren't, in practice for 30 or 40 years are more used to the systems that we're dealing with now. To circle back just a little bit too about this, it kind of gets us to this question of what kind of background or skills or attitudes would a physician preferably have if they're going to fill this kind of a role? Could you comment on that?
You had mentioned before that being a physician is not necessarily the end point for some career paths. And most physician advisors need to have 5 years of clinical experience. Mm-hmm. Just because of the need to understand how medicine is practiced and how the health system works, and to have other physicians willing to kind of defer to your expertise. Really, you need to be somewhat experienced. You've already alluded to the fact that you need to be comfortable with communicating with other physicians and influencing others. And sometimes these discussions can get tense, and so it's important to be able to remain calm, under those circumstances, and to not take things personally. Having prior utilization review experience is helpful, and that can be in the form of just having worked on your hospital's committee. And I would say generally the most common specialties that do this work are hospitalists and primary care specialties, but you do see some emergency room doctors and even some surgeons that will get into this work.
This isn't a job you can just sit somewhere in a corner and not interact with people, I guess is what I'm hearing for sure. So you definitely have to have those skills.
Yes, for sure. Although, again, in the old world, when the physician advisor worked remotely more commonly, I mean, that could be something that was done from home, and you needed to be good on the phone, but you didn't have to do the face-to-face component. That's definitely changed.
Now, are there certain educational courses or certifications and so forth that one can access to try and learn some of these specific skills related to care management? Yeah,
actually, before you even land a job, there are conferences that you can attend that I think are great for beginners. One is produced by the American College of Physician Advisors, and it's typically held in Greenville, South Carolina. The other is one called the National Physician Advisor Utilization Review Boot Camp, and that's also an annual conference that's put on by a company called Global Healthcare. And the first one I mentioned, the American College of Physician Advisors conference, is usually attended just by physician advisors or those interested in becoming physician advisors, whereas the second one is really for the whole care management department. Compliance officers will attend that, nurses, care managers, coders, in addition to physician advisors. So the two conferences have a slightly different feel, but I think they're both great for the beginner. The American College of Physician Advisors also publishes a textbook for the new physician advisor, and they also sell a pocket guide on their website. And they've collaborated with the American Board of Quality Assurance and UR physicians to establish a board certification for physician advisors. And this is a real legit board certification. It's administered through the National Board of Medical Examiners. And so there isn't any fellowship requirement. You don't have to go back to being like a resident, but there is coursework, and you do have to sit for a board exam for that. And so these are all things that you can do even before getting a job. But there are some opportunities where if you work for a company, they'll train you. Mm-hmm. So, if you were to look through some of the typical places where you would find job ads, there's some companies that will offer training in addition to the position. Usually, I think that's probably in exchange for some time commitment to remain with that company. Mm-hmm. But other than that, the only other place I think you might learn some of these tasks would be if you were to serve on your own hospital's committee, or if you have a physician advisor within your health system, to introduce yourself to that person and find out if they can connect you with any opportunities.
That's a good point. One of the things we talk about commonly on the podcast here is the use of mentors. And so I would agree 100% that if you have any interest in this, just having an occasional conversation with a physician advisor or someone in your role as a medical director for care management and just pick their brain a little bit and they can send you in the right direction generally.
Yeah, I agree totally.
Now, one of the other thoughts I had is whether there might be some kind of journals or newsletters or other information that an interested physician might be able to access.
Well, I would direct your listeners to two organizations. One is I've already mentioned, American College of Physician Advisors, which I think it's worth mentioning, is a nonprofit organization and really has done a lot to provide a space for dialogue and a lot of resources for physician advisors, like that textbook that's been made available free to members. So just joining that organization, you can get an electronic copy of that textbook for free.
Very good.
And also, they have the pocket guide as well. But there's a blog, and they do publish articles on the website on a pretty regular basis. But then there's also the National Association of Physician Advisors. Now, this is not a nonprofit organization, and they may also have publications. I'm less familiar with them, because really my experience has been that they really focus on putting on conferences, and they do some excellent conferences as well. Just the focus of the organization is a little bit different because it's not a nonprofit.
Got it.
But you could go to either one of those organizations' websites and fairly quickly, find your way to either online publications or a means to get publications that you can get offline.
Very good. Those are a lot of good resources for interested physicians. Now, one of the things that comes up, I'm going to shift gears here a little bit, is whether a physician can make a salary that's commensurate with what they might make clinically if they decide to go down this path of physician advisor.
I think it depends on what specialty you start in. There are going to be certain specialists where this could involve a pay cut. But for most primary care specialties, this is going to be a pay upgrade. And so the American College of Physician Advisors has completed a benefit survey of its membership twice now. And then the most recent one that they completed was released a few months ago. And it indicated that the average salary for a physician advisor is between $200,000 and $300,000. And there's some that make well above $300,000 a year. And it's going to depend on your specialty, the years of experience, other credentials that you bring, such as if you have an MBA or an MPH. It depends on the number of beds that are in your hospital or in your hospital system. It'll depend on the region of the country that you're in. But most will also receive the standard benefits, life, medical, dental, these sorts of things, and a CME allowance. And it's also very common to have an annual performance bonus as well that could increase the earning potential.
Right. That's sort of, you had alluded to earlier, the fact that this is sort of a stepping stone sometimes to even more of an executive type career. But when you mentioned the bonus, that's something that's definitely built in by big health systems and hospitals to reward, performance. So that's definitely a positive thing. It sounds very competitive with the clinical salary, like you said, unless you're, a neurosurgeon or something like that, perhaps. Well, any other thoughts you'd like to leave with us today about this career choice for physicians? Any other bits of advice or positives and negatives that you make sure that the listeners are aware of?
Well, I would say that the field is growing. There have been some physician advisors that have been doing this for 15 or more years. And I kind of note this from that benefit survey that the ACPA recently released, that when they surveyed how long people have been doing this, the vast majority have been doing this for under 5 years. And so the specialty is really growing given the number of people like me who haven't been doing this that long. And I find that the job security is great. As you can see in my situation, I went from being the only physician advisor to showing the value such that we're growing our program and we're not a very big health system.
Right.
But there's a lot of value in having relationships or being able to build relationships. So even if it may seem daunting that you have to manage conflict, I think with the right strategy, that really isn't as much of an obstacle because of the relationships that you can build. And that's also why the field is moving more towards having the in-house physician advisor. And in our program, the four that we have now are all in-house. And, we just use the external vendor to cover emergencies.
Got it.
And even though I think for me personally, my bedside skills are a little bit rusty, I still see patients, by the way, just a few days out of the month. It doesn't mean that my critical thinking or my clinical acumen is any less good. In fact, I think this work has sharpened those things because of the need to do extensive chart reviews and be able to have discussions and negotiations with other clinicians about clinical matters. Another kind of important task in this field is understanding regulations, in particular the 2 midnight rule. That's perhaps one of the most important changes that have come along in the last few years. And even understanding that isn't enough because not all insurance companies will follow that. The 2 midnight rule is really a traditional Medicare thing. So it's important to understand the contracts you have with your local insurance companies and how they relate to the 2 midnight rule. And so, this is really kind of a challenging area that most physicians don't want to get into. And so if you have an interest, there's a lot of job security because, you really offer value in being able to make sense of this kind of confusing space. And as a result, bringing the kind of value that CFOs like because you're preventing losses and at the same time, hopefully promoting patient safety.
Well, that was very useful. So a couple of observations, I guess, in response to what you were just saying. Number one is if you're on the verge of retirement and want to do something easy, this is not for you because you need to be focused. You need to have really excellent clinical skills and understand what's going on in a complicated environment. The other thing that I heard you say, which I think is really true, is that since you're definitely having an impact on patient safety and quality because one of the things that can harm patients is being in the hospital when they shouldn't be. So I don't think our colleagues always want to acknowledge that, but the quicker you can get someone in and out appropriately, the better for their quality and for their safety as far as being in the hospital. So that's an excellent point.
Yes. Yeah. Thanks for pointing that out.
Yeah. That's just key. And
the strategic planning that I'd mentioned in the beginning of our conversation that I'm involved with relates to that.
Mm-hmm.
And I'll just comment that I've been tasked to devise strategies to identify patients that are at risk for readmission, but also tasked to develop a strategy for our hospital system, which has 2 hospitals, for managing our high utilizers, patients who use resources at a higher rate than the rest of the population. And so these are pretty time-intensive, data-focused tasks that I really enjoy. And so it's been something that allowed me to use other skill sets that I really couldn't use when I was just 100% in clinical practice.
Mm-hmm. I'm sure that the audience is going to really appreciate your comments and input and advice. It's been great. Some of them might want to reach out to you in some way. Is there some way they can contact you, perhaps through LinkedIn or something?
Yeah, I don't have a significant social media presence, but I do have a LinkedIn account, and I'd be happy to make connections that way. You can find me there under Timothy Owolabi. I'm also happy to communicate by any of your listeners who want to reach out to me by email. They can find me at towolabimd06@gmail.com. And so just reference the podcast. I'd be happy to communicate with anyone who has questions.
That is fantastic. I thank you so much, Tim, for being with us today. This has been very helpful, very informative, and I will put links in the show notes for anything we've talked about in terms of the various resources and your email and so forth. And again, I just want to thank you for being on the podcast today. It's been a really interesting interview.
It's been a pleasure. Thanks for having me, John.
You're welcome.